Welcome, everyone. Good morning, good afternoon, good evening from wherever you are joining us from. Thank you for attending the first in our webinar series in Innovating Mental Health. My name is John Patenya. I am the Director of U.S. Mental Health Programs here at HealthRight International. For over 3 decades, HealthRight has advanced community-based mental health solutions in low-resource settings worldwide. In the past few months, we have launched a U.S. mental health program to bring this expertise home. Originally developed for use in low-income countries, these low-intensity psychological interventions can be adapted for vulnerable and underserved populations in the U.S., offering an innovative, low-cost, and scalable solution for mental health care. In recognition of World Mental Health Day that occurred earlier this month, we are kicking off this webinar series to discuss building partnerships. We will answer the questions: what are low-intensity psychological interventions? What makes it innovative and low cost? And why scale up in the US and why now? I'm excited to facilitate a conversation with an esteemed panel representing a variety of perspectives and what building partnerships means to them. But before I introduce our panelists, I'd like to share a few slides to set the stage up for our conversation today. So if we could launch our first poll to get some audience engagement, we'd love to hear, where are you all calling in from? If you're in the US, from the Northeast, the South, Midwest, West, or if you're joining us from outside of the US. And while folks respond to the poll, please feel free throughout the webinar, please put all your questions into the Q&A function in the Zoom webinar. Our team members here will be monitoring the Q&A function. Great. Thanks, everyone. Okay, we can end the poll. And we can share. Looks like a lot of us coming in from the Northeast. So thank you, everyone, for joining. Really appreciate you joining us today. So to get us started, the U.S. is experiencing a mental health access crisis characterized by several factors. 1 in 5 people in the US live with a mental health condition, yet only about half receive some kind of treatment. And often that treatment is traditional one-on-one therapy. It could be a combination with medication management. And mental health is still a very stigmatized topic in many communities. It is not a topic that is acknowledged or openly discussed among families, and these negative attitudes significantly hinder seeking care. There is limited availability of services, so over 80% of those living in low-resource settings do not get adequate mental health services. So often, waiting times to see a mental health professional can take upwards of up to 6 months. And on top of that, there's a workforce shortage. There are not enough mental health professionals, so psychiatrists, psychologists, social workers, counselors. There's not enough for the need of the population. And this all contributes to the high cost of healthcare. So current mental health solutions are heavily dependent on expensive trained professionals. And when you factor in the inequities in health insurance coverage, accessing and utilizing mental health care is truly a challenge. HealthRight's solution to this crisis is our step care model to mental health. On one end of the steps, we provide psychoeducation, we can provide screening, and it's important to note that this model has been developed for those experiencing mild to moderate mental health symptoms, particularly depression and anxiety, collectively known as common mental disorders. Now, the focus of our conversation today is low-intensity psychological interventions, which utilize non-mental health professionals to provide some level of mental health care. These are often trusted community members, peers, or community health workers. And there's a variety of tools that are available depending on what the target population needs. Some tools are self-guided, others in a one-on-one setting, while others in group settings. Now, the suite of tools are first and foremost evidence-based. Has been developed and endorsed by the World Health Organization and has been demonstrated its effectiveness in multiple contexts globally. At HealthRight, we have done this as well in our country offices. These interventions are effective. They address nearly 96% of those living with common mental health issues. Relevant to our conversation today, these are low cost. Since these are peer-led and care is provided by trusted community members, these interventions are a fraction of the cost of traditional mental health care. And most importantly, these interventions are scalable. These interventions can be replicated across a variety of communities. I like to describe the step-care model as one, an entry point into mental health care for those that are hesitant to engage in traditional therapy or have that stigma around talking about mental health. And two, serves as a pipeline for those that do need more comprehensive services. So with that as our setup, I'm excited to introduce our panelists today, where we'll be discussing these topics and for our panelists to talk about their perspectives. So first, I have Dr. Herman Corso, the co-founder of the Shipbox Foundation. Dr. Corso, I'd love to invite you to introduce yourself and the work that you do.
Thank you, John. Hello, everyone. I'm very happy to be here today. My name is Herman Corso. I'm an adult child and adolescent psychiatrist. I've been in practice for 15 years. I'm also an associate professor with UTRGV School of Medicine and with St. James Medical School. I'm a co-founder of a Shrinkbox. It's a nonprofit foundation that is located here in the southernmost part of Texas, Rio Grande Valley. And our foundation has the mission of closing the gap in mental health. We serve at different levels with different initiatives and projects in our community, and very excited to be here today.
Thank you, Herman. Mentala Ishmael, who is the founder and executive director of the Refuge Collaborative, invite you to introduce yourself and the work that you do.
Yeah, thanks, John. Hi, everyone. My name is Mentala Ismail. I am the founder and executive director of Refuge Collaborative, which is a nonprofit organization that focuses mainly on education accessibility and health promotion for refugee youth. We primarily work in the Midwest, so shout out to Ohio and Kentucky. That's kind of where most of our work is at. And I'm currently a DRPH student at NYU School of Global Public Health. I'm excited to be here. Thanks for having me.
Thanks, Mentala. Next, we have Dr. Jonathan Purtle, Associate Professor of Public Health Policy and Management at NYU School of Global Public Health. Jonathan, if you could introduce yourself.
Hi, everyone. Thanks for joining. Most of what I do related to mental health is research. I study the implementation of mental health related policies here in the United States and the effects of various mental health and economic policies. A lot of my work focuses on financing, different financing models for mental health services, and also suicide prevention interventions such as crisis lines.
Great, thank you, Jonathan. And finally, Dr. Nawaraj Upadhyaya, who is my counterpart. He's the Director of Global Mental Health Programs here at HealthRight International. Nawaraj, if you could introduce yourself, please.
Thank you, John. Hello, everybody. I am Nawaraj Upadhyaya. I'm from Nepal. I'm actually calling you from Nepal now. I am the Global Mental Health Director at HealthRight International. As John has explained, our org. I won't go on that, but I am also a guest researcher at University of Copenhagen Global Health Section in Denmark, and I am in a mental health system person with policy to practice nexus. Thank you.
Thank you, Nawaraj. So panelists, thank you so much for being here. Truly an honor to have all of you here to speak not only on your perspectives, but to really discuss what does mental health look like in the US. So even though I have some prepared questions for us, I do want this to be a conversation. So anyone can feel free to kind of chime in as information is kind of brought up. My first question is geared toward Herman and Mentala. So Herman, if we could start with you, what emerging or unmet mental health needs are most pressing in the communities that you serve? And how would you like to see mental health care change to better meet those needs?
Thank you, John. It's a great question. Let me start by describing a little bit of what our community looks like. As I mentioned earlier, our foundation serves the southernmost part of Texas. So a bunch of different cities that are on the border with Mexico. We have about 1.4 million people that live in our area. Our main ethnicity is Latino. As you can imagine, there is a lot of crossing from the border, a lot of informal working. Many of our population are only fluent in Spanish, and that really makes our population very unique. We're home of some of the poorest cities in our nation, have a lot of needs and vulnerable population that we serve. As you were talking in your introduction, the biggest and more important unmet need has to do with mental health access. Not a secret, it's something that we are all experiencing in our country. Roughly about 21% of adults in the United States suffer from mental health problems. That means for us here in the Valley is about 210,000 people. When we talk about children and adolescents, we estimate about 40 to 50,000 more. Majority of these people are not getting any kind of services. Roughly about 45% of people get services, and that means that we are having probably anywhere from 110, 115,000 people that are not getting any services. So when we talk about the work we do with our foundation and how we can close the gap in mental health, we've been working on identifying some of those big barriers that are making it hard for us to increase the health access in our community. Not surprising, the number one has to do with stigma. We're still having lots of stigma surrounding mental health, difficulties with people understanding that mental health is a priority and that it's normal to suffer from mental health problems. Still feeling that our community thinks that seeing a mental health provider is a synonym of being crazy, and I think that's the biggest battle that we have. When we talk about the unique demographics of our population here, being a majority Latino, that's a little bit harder and more embedded into the cultural background of the people that we serve. Another big barrier that we have identified and unmet, having us be not having enough access, has to do with shortage of mental health providers. I think this is definitely a big one that is not just unique to our region, but is nationwide. I don't think we have enough mental health providers to cover the amount of people that need our services. And I think, particular to our region, we were even at a worse position, not only because we're in rural parts of Texas, but also because we need mental health providers that are fluent in Spanish. And, since we're already short to begin with, you can imagine that the percentage of people that are, fluent in Spanish is even lower. So that's a very unique characteristic of our region that makes us a little bit worse than other places. A third situation that we have seen that has taking a big toll in not having access to mental health services in our region has to do with folks don't having insurance. We know roughly about 11% of people in the nation that have mental health illnesses do not have insurance. And I think particular to our region, that can be a little bit higher if we consider, informal crossing, unlawful legal resident status. And I think that might be a little bit higher in our area because we live so close to the border. And that really puts a toll on people receiving services. Cost of services is really high. So I think that's definitely another area. And the fourth element that we have identified as a big barrier for mental health access has to do with education. I think we still work in a mental health scheme where we are working as a reactive, as a treatment group. We focus our services more as someone develops mental health issues, and we are jumping in to treat, with therapy, with medicines or whatnot. But we are not really doing much to educate the population on early warning signs and ways of preventing people to derail the course of illnesses to get to more severe forms of illnesses. The premise that we have in our foundation is that if we're able to prevent people from the developing more severe forms of illness, we might be able to have lower intervention or lower intense interventions that can be helpful before it gets to more severe forms.
Thank you, Herman, for sharing that. And as a follow-up, just in after Mentala shares her part, you mentioned a lot about the access, and including in terms of stigma and shortage and the education piece. And I'm wondering also around utilization, right? So in public health, we talk about there's barriers to access, but then also barriers to utilization, and how kind of stigma might play into that. But Mentala, I want to kind of go this over to you now. What are the mental health needs most pressing in communities that you serve? And same question around, how would you like to see mental health care change to better these needs?
Yeah, absolutely. I echo a lot of Jermaine's sentiments. And so just a bit of background on what Refuge does is we are a nonprofit organization that works primarily with mentorship. And that's what we serve refugee high school students specifically, and their mentors are college students, undergraduate college students. And this type of mentorship is hosted once a week. It's in person. And that's a big part of our model, and why kind of it does address these psychosocial, connectedness factors that we're looking at. And I think with Refuge, so again, in terms of like platform and what we have, we're in about 8 institutions. We have 8 chapters, so 8 chapters of undergraduate college mentors, and we work within 3 to 4 school districts between Ohio, Kentucky, and Chicago. And so we see a broad range of students. And while Refuge has emphasized that we work with refugee students, as we probably all know, that is in terms of status and labels, that can mean a lot of things in terms of citizenship and folks who are coming in, and young adults who are coming in with different statuses. So we work with unaccompanied minors, undocumented students, so a range of youth that are coming in with different needs. And so they're coming into school systems with different cultural backgrounds, different identities, language barriers, and a lot of times the schools are low resourced and don't have as much of the mental health capacity or coordination that is needed to address English language learners, which is where they usually are housed in the schools we work with. And so in terms of unmet needs, I think I'd be remiss if I didn't kind of focus on the immediate needs in terms of our political climate. I think that has severely affected the refugee youth that we work with, or the migrant youth that we work with. So we're seeing trends really decreasing in terms of students showing up to school, and just being able to be present in these areas. And so with Refuge, part of what we've been doing for the past 8 years is creating this welcoming community and around identity and belonging for migrants, for refugees, for asylum seekers. Currently within the schools, that is where those tend to be safer environments. They have not been just that recently. And being able to, there's just like a lot of information that's being thrown at the students that we work with, both our mentors who are also young adults, undergrad students, and might be on campuses that, you know, do have hostile messaging, along with our refugee youth who are now in very unwelcoming communities and don't feel safe coming into schools. So in terms of the unmet needs, I think it's going to be around community support and approaches and showing up and making sure that our students do feel that there are zones that they're safe and that that messaging does not spread. Stigma is huge just in general when you're working with this population. And we talk a lot about cultural competency. And I remember when we first started out with Refuge, that was one of our main thing. We're gonna culturally competent mentorship for higher education, for health promotion. But throughout our time working within these schools, we kind of figured out what that actually means. And the goal of cultural competency is not a simulation. I think a lot of times that gets a bit confused. And so creating spaces where our refugee youth who come from all around the world, with Syria, Somalia, Uganda, Venezuela, are able to celebrate who they are and be who they are, knowing that they are young adults to their teenagers in high school. Like going through high school is tough enough without, the background of resettlement and all these needs, and for most of them being primary caretakers, etc. And just being able to have that space where their culture and identity is not only celebrated, but there is space and room for it. And most times in these systems that we work within the US specifically, which is where Refuge works, the systems are not created for these cultures and backgrounds. So that is what I have to say on that.
Thank you, Matala. And from what I'm hearing too is part of the challenge is that there aren't these safe spaces in school settings. And I imagine that kind of bleeds into healthcare settings as well. So if we thinking about where mental health care can actually be provided, it should be in these places that should be safe for anyone. But that there's this extra level of not even just a barrier. It's just it's an incredible challenge. Thank you for sharing that. Nataraj, I want to bring the question to you around can you share an example from your global experience where low intensity interventions improve mental health outcomes for a community? We've heard now from Herman and Matala around challenges in access, stigma, a shortage of providers, that safety component. What has your experience been like implementing this in a global space? And what is one lesson from the work that you do that you feel is relevant here in the US context?
Thank you, John. Am I audible?
Yes.
Okay. Actually, the improvements that we have seen in our global work are in terms of symptom reduction for common mental health problems such as depression, anxiety, and PTSD. And second one is improved on daily functioning, such as coming, doing your day-to-day work, and then improved psychological well-being. These are the three main outcomes that we have seen as improved through our low-intensity interventions. This suggests that low-intensity approaches can significantly reduce psychological distress and enhance well-being even when delivered by lay counselors or the lay health workers, or either in person or through digital platforms. We have used interventions such as self-help plus, problem management plus, step-by-step, interpersonal group therapy, and these intervention actually have really helped us to address the last treatment gap by extending care to the population where specialist services are scarce. As you know, in many of the low-income countries, where we work, the specialist services are very scarce, and it is very difficult to get the specialist in rural areas. The improvements are, however, small to moderate and clinically meaningful for many participants, as these are the low intensity interventions and are delivered by lay people. So the improvements are also small to moderate, but very meaningful to the participants. This means many people benefit, but these are not replacement for specialist care for severe disorders. That's why we actually ask that these interventions be implemented as first-line preventive interventions, and they are actually connected to other higher interventions in a step care model, as John has presented earlier. The one of the aspects that I should actually highlight here is that those low intensity interventions are great when they are delivered by lay people, but the improvements tend to fade away after 6 months of 12 months of period. Hence, I think in the US and also in other countries, what we need to do is that we need to sustain those impact through a booster session, continued supervision, community engagement, and integration of these low intensity intervention into broader health and social services. When talking about one or two lessons for US, I think the low intensity interventions after adaptation and contextualization in the US context need to be placed in a step care model, starting with a very low intensity intervention and gradually moving to higher intensity intervention. That means offering the low intensity options first, and then, for example, in our case, we can offer doing what matters in times of stress is a very low intensity intervention developed by WHO, which we also piloted in Uganda, and then we can slowly move to self-help plus intervention, and then to problem management intervention, and finally to individualized therapy and specialty care when needed. So this reduces wait list and matches intensity to need. So not many people need severe mental health solutions. They actually can also be their problems can also be addressed by low intensity interventions. Another aspect is that we have to have established referral mechanism. Without established referral mechanism, we don't suggest to implement low intensity interventions, because there is a risk of any problem that are unattended, because at times we take these low intensity intervention as an identification of severe mental health problems that need immediate referral. So referral mechanism has to be there, and it has to be functional. And finally, during the adaptation and contextualization process, we have to be mindful that we can change the language, case examples, delivery formats, but we should not change the main ingredients of the intervention. Otherwise, it will become kind of mixed match. That has happened in many of the settings where other researchers have reported the changes in the ingredients, and that really damage the productivity of the intervention. And finally, from our low income countries experiences, we can say that in the US, to improve the long-lasting impact of the low intensity intervention, we need to have a booster session focused on regular refresher training, routine coaching, fidelity checks-in, and joint case conferences. Thank you, John.
Thank you, Naraj, for sharing that. And there's so many layers to the step care model that I'm hoping provides a maximum kind of impact and support for any population. So now I want to bring this to Jonathan. Now that you've heard the challenges that we're seeing here in the US, and the kind of potential benefit of a step care model. What do we need to do to actually make that happen here in the US? What kinds of financial and policy supports are needed? What changes in infrastructure do we need to set up for that to actually happen?
Yeah, totally. Thank you. So, sustainable financing is really, really a big thing, right? So here in the US, we primarily have a fee for service model, right? So providers get paid for every unit of encounter, right? So there's a lot of challenges when it comes to, low intensity interventions kind of entering that fee for service space. So one is, who's going to pay for it, right? It's pretty hard to make private insurance do anything related to specific interventions. The best bet is probably Medicaid and getting state Medicaid agencies to develop a code for a specific, low intensity mental health intervention in a state. That brings the question, when you have a reimbursable service, it is codified who is going to provide that service, right? So I've been involved with some work, and that can be really challenging. There aren't healthcare provider codes necessarily always for the types of folks that deliver low intensity interventions. The American Medical Association maintains a taxonomy of healthcare provider IDs, right? So every type of provider, there is a number associated with that. Community health worker, luckily, is one of them. That one is pretty broad and pretty workable. I was fortunate enough to be involved with a project in Philadelphia for what I would call a low intensity mental health intervention focused on providing trauma focused services to victims of violence in Philadelphia. We were able to create a new code for violence intervention specialists and get Medicaid to pay for that in Pennsylvania. So it's possible, but it's a lot of work. And then there's the whole claim side of thing, right? It's burdensome to submit claims. You need a lot of infrastructure, you need expertise. And if, the reimbursement rate for this light touch service provided with someone, who's not a physician, it's going to be lower. And it can be really challenging, even through that model, to sustain the services if the amount for the reimbursement is not enough. Another challenge there is credentialing, right? So let's say you create a new type of provider to deliver these light touch interventions and have them reimbursed. There has to be some sort of baseline training and quality assurance. Who's going to hold that and how that going to be maintained? But again, this is just to say, it is a pathway. Medicaid reimbursement is a pathway to sustainability, I think, for these sorts of interventions. A completely alternative model is some sort of earmarked revenue stream for these low intensity interventions. So colleagues and I have done a lot of work around earmarked taxes for mental health. So an earmarked tax for mental health is a tax on a specific thing, and all that money goes into a pot, which is then dispersed for mental health. So for example, in Washington state, counties have the ability to vote at the county level to increase their sales tax by 0.1%. All of that goes into a pot of money that can be dispersed out to the community for a really wide range of mental health related interventions. So a lot of flexibility in that spending. And I think for these sorts of interventions that don't really fit the box in a fee-for-service model, that type of funding approach can work. Some states are doing this with tax revenue, excise tax revenue from cannabis, right? A lot of money coming in. It's excise tax, a new pot of money. Some states are allocating some of that for mental health. And I think that could be a great source of sustainability. Last example, I do work related to the 988 Suicide and Crisis Lifeline. I think we can consider that a low intensity mental health intervention. A lot of states are passing telecom fees to finance that. So this is how the 911 system is financed in the US. It is a flat fee on everybody's cell phone bill in the state every month, something like 15 cents a month. All of that goes up to the state level, a big pot of money, and then through various decision-making mechanisms, that gets allocated back out to the community and service providers. So between those two approaches, the typical fee-for-service reimbursement model and trying to attach these low-intensity interventions to some sort of less restricted financing source, I would think the latter would be a more workable approach. But then the big question is kind of the politics of that is, when you have these fees in place and we have this money coming in, a lot of people are reaching for that money and trying to be a line item in that year after year.
Thank you, Jonathan. I think, first of all, both are really challenging, right? And so I'd love to hear from the fellow panelists, like, the first model around fee for service and reimbursement, there's a lot of kind of layers to that. And the second model around kind of earmarking taxes and kind of saving that. what do you think would work in your kind of local context? So like Herman and Mentala, what is it like in Texas, in Ohio, and Kentucky for either of those options?
Yeah. Or sorry, no, go ahead. No? Okay. I think a lot of times, or I think in Ohio specifically, when Dr. Pearl was specifically discussing this aspect of like restricted funds or earmarking funds for mental health, that is the big challenge that I and my team with Refuge or other community-based organizations who do work with refugee and migrant youth haven't come into like barriers when we're trying to access these types of funding to work specifically on these types of models that do address under the underlying mental health issues that come from like these psychosocial factors. And so for us, it's always it's very rigid, and that is just how it's been. For example, in Ohio, you have to meet very specific like grant line items, and you have to meet these different things that you're being asked, but those things in these grants and where the money is being allocated does not necessarily cover the needs that are of the population that we're serving. And that has been true for Ohio, that's been true for Kentucky. And also these states do tend to lean more on the conservative end. So that is also something that we kind of run into when we are trying to propose different interventions in terms of also what we can do within schools and within specifically the youth we're working with. And so yeah, the idea of like these unrestricted funds that could be earmarked for specifically mental health services or services around like connection and belonging for youth, that kind of seems to be where we would hope to head in terms of the work that Refuge does.
Thanks, Mentala.
Yes, I think I have a similar view to what Mentala was saying. I think it is highly needed to have these low intensity, lower cost interventions, especially because we do need to increase access of mental health. I just don't know what is the best route to go and how can we overcome some of those financial challenges. I know that we definitely need to put our heads together and see what will work better or what model will be a more feasible model to implement. I think looking into grants that can perhaps be allocated to be able to start these services or allocate some financial resources to these services, maybe doing some strategic partnerships with already established entities that are providing services, and maybe how we can incorporate some of these models into what they're already doing. I'm not so sure that I see the route with Medicaid being. It sounds like it's pretty new and novel, and in my experience, that's always been a challenge, to implement things when you are providing a new service. It requires some adjustment period, but what I really see is incredible is that these are evidence-based strategies that we have the evidence to show that they really have helped, as we heard from when Nawara was sharing with us some of the work they have done outside, and I know it's been published. So I think that can make it easier. I just don't know what is the best way to implement it at a financial level to make it successful.
Jonathan, I'm wondering if you could kind of share insights here, because you mentioned that between the two options, the latter of kind of earmark tax is the most. I don't know if please correct me if I'm wrong, if you use the phrase more feasible or more likely than the first option. But my question is, what can we do about it, right? So this conversation is centered around building partnerships, and in the public health space, we say that a lot. We say partner between organizations, between private public. What does that actually mean, right? And in this context, partnering collaborations with policymakers to kind of push that agenda through. What do we actually need to do to make this happen?
Yeah, totally. But in this conversation, in this context, to me, partnership really means kind of like establishing trust and understanding. So, right, with the earmarked funding approach, let's say you're doing one of these low intensity interventions in a state that has some sort of tax earmarked for mental health. There is some pot of money at the state level that's being dispersed, and you want some of that money for your intervention. Yeah, I mean, I think it means building partnerships with state legislators who normally have some role in that decision-making body and members on the body more broadly. So as I said, kind of a potential challenge with that funding approach, again, these fees is accountability. And with that, I think these decision-making bodies who decide how this money is allocated, when a new entity comes along trying to get a piece of the pie, if you will, they're often met with skepticism, right? So I think the partnership approach means developing trust and really educating those entities about what this intervention is, showing that this is like a real important evidence-based, hopefully, public health intervention. I also think this one more thing about partnership is I think, partnerships, let's just say that the funding issue is not an issue. For whatever reason, you have funding, you have your low intensity intervention. You want people to have trust in the community who would use that intervention to have trust in that intervention, right? A whole other area of trust. So there, I think partnering with other organizations, trusted entities that work with those communities who you're trying to target and get engaged in your intervention is a really important area of partnership. Otherwise, you can build it, have it sustainably financed, but folks won't come.
Thanks, Jonathan. And now, Raj, I want to invite you to, on this topic of partnerships and, what has your experience been like in terms of partnering with ministries of health or with policymakers or kind of this conversation around earmarking taxes? Have you seen something similar in your global work?
Yeah. In a low income, low and middle income countries that, my work is, primary focus is quite challenging to get a tax, refund, insurance, coverage. But what we have been doing is that actually we have been integrating mental health and this low intensity intervention into, partners regular programming, so that you actually, they can actually, after our training and supervision and joint, implementation, they can run this program on their own. For example, we integrated self-help plus intervention into Ministries of Health in Uganda's COVID-19 response plan, so that after our training and supervision, they were actually able to run this program on their own from their own budget. So this is one way of financial sustainability in low resource setting. How to find resources that can actually really help to scale up the intervention. Secondly, we also integrated self-help plus intervention into Barak, Uganda's livelihood program, so that they already have the livelihood program funded. That's the core business that they do generally, so they will get projects on livelihood anyway. So if we integrate self-help plus low intensity intervention into their livelihood project, then it becomes sustainable. Similarly, in AMREF Health Africa South Sudan, we integrated our low intensity intervention into their conflict and health program, so that this can continue. So I think this is one way of actually sustaining funding through by partnering with the government, NGOs, and CPOs, and even the United Nations organizations.
Thank you, Naresh, for sharing that. And it's one of those things that right where our discussion today is what is the catalyst that needs to happen around I think we've delved into the challenges, the potential solutions from across these kind of different perspectives, right? So the solution in terms of the actual mental health intervention, from the what participants, what communities need to experience, but also the solution around how do we get it funded, how do we get it sustainable, and Narwa sharing these success stories in kind of other countries. I'm curious to ask the panel, and anyone can ask this. What strategies can we take now, short term, in let's say the next 6 months, to overcome the challenges that we've identified in our conversation so far? What can we do from academia, from a community-based organization, from a health system, from an NGO? What steps and strategies do we need to take now?
John, I think this is very important because we don't want to get into analysis paralysis where we're not really making much of progress in what we really want. I think this is a very highly needed service, and we, I definitely see this making a big impact in my community. I think for me, in my personal view, the biggest challenge is going to be sustainability and funding. And I think I understand, strategic partnerships to be the way to go around this. I think we need to, I will propose that doing some search of who is a potential agencies, organizations that we can partner with, where we can start perhaps introducing some of, maybe starting a pilot with a smaller, I think Jonathan was mentioning something that is, I think, quite important, which has to do with trust. I think he mentioned the word trust multiple times. And I think a pilot usually brings trust, because if you have a successful pilot, it's easier to escalate it to a bigger, a more sustainable project later in life, or in anything that you do. So I think it's important that we perhaps try to explore at the communities that we're hoping to target. How can we incorporate some of the successes that have happened outside of the country and in the implementation, and maybe make a small pilot that can be, the opening the door to be able to reach to legislators, reach to other people with something that shows some of the potential progress that we can make, and impact is the word I'm looking for, that we can make in our community. I can tell you right now, many places, many of my patients, they need to wait a whole year to get counseling, right? And I can see how, some of these peer-based interventions can be incredible. I was talking earlier about prevention, in mental health. And I think this is prevention. If we are able to work at the level of, helping peer for those people that need help, but maybe for a variety of reasons, whether it is insurance, whether it is access, because we don't have enough people providing care, or whether it is a stigma, we can have people there, peers, that can provide those services that can prevent them to get from more severe mental illnesses. So I think that's my personal view, and how I think, what kind of things can we do now?
I wanted to add on to that. Yeah, and I really appreciate this analysis paralysis thing that you brought up. I think it's really important. For me, and kind of from the lens from a smaller nonprofit that is on the ground, and like talk about bootstrapping and kind of just doing the work day in, day out with these community members. The issue that I've been seeing actually for the last 8 years, but more so in the last few years that Refuge has been doing this work, is in terms of like capacity and funding. And so we've been talking about funding, and kind of an immediate 6 months fix would be, we're having this conversation, there are folks on this call, we're connected to different institutions, etc. Partnering, we're having these strategic partnerships with smaller organizations who I would even urge that are led by the members, back to trust, by the members of the communities that we are talking about. A lot of our Refuge, a lot of our programming is designed and led by refugee youth, and I think that is part of what makes it why it is successful and why it runs the way it does. But I do think kind of having those, understanding the broader vision. So for refuge, while I am looking at refugee youth, and that is kind of where our focus is, we understand that with refugee youth, they're often, or migrant youth as well, they're often the brokers between their family members and healthcare systems, or just systems in general. And so understanding that broader vision, and trying to, with institutions who do have the funding, or with organizations who can potentially earmark those things, and work with smaller NGOs, or NGOs that are just on the ground doing the work, and prioritizing that, like being very intentional, and trying to find those organizations and working with them. I think that is kind of where my head's at in terms of like the next 6 months. But also, right, hand in hand, listening to the community itself. So we talk about this often. It's not novel, right? You go in, you ask them what they want, but I think not just asking them, but like having them be part of the design, having them be the design. And while we have the technical skills, maybe that's where I show up, is I have the technical skills to design it, or to put the right words to it. But maybe I the idea should come from them in and of itself. So giving them that platform, in terms of what is needed in the next 6 months, is what I'm envisioning.
Thank you, Matala.
That's one. I'll just add one thing. I agree with all of that. I mean, I think this might not be next 6 months, but I think it's important and could happen kind of soon. Be a concerted advocacy effort from different programs that provide low intensity mental health interventions. So there's a lot of programs out there, but they're often pretty standalone, right? And they're all working really hard just to stay afloat. Some sort of convener, if you will, to bring these together and then kind of launch some sort of national advocacy push at the state level, at the federal level, could be really important to the funding piece. Going back to this hospital-based violence intervention program I mentioned when I was speaking before, that happened. There were about 20 different hospital-based violence intervention programs across the US, all operating independently, their own funding, all kind of doing similar stuff. And an organization called the National Network of Hospital-Based Violence Intervention Programs got together and kind of served as the roof to convene and then launch some national advocacy. And I think it was pretty effective. So I think that could be a big piece. Just one thing I want to note, and this is not an opportunity, it's more of a challenge, but I think it's important to keep in mind, is the force around AI counseling and AI chatbots. I am a Luddite. I'm not super supportive of these things. I don't think they're ready to go yet. But unfortunately, the powers that be behind them have a lot of power and they have a lot of money. And that is potentially going to be a competing force in this market of, not resource intensive intervention. So start thinking now about the narrative, about how these person delivered low intensity interventions are superior and really valuable in ways that an AI counselor never could be. Starting to think about that now may be important.
Thank you, Jonathan. Naraj, do you want to mention anything?
Yes, I actually want to share that, building a partnership is a long process. It requires time, resources, and patience. So actually, I think we should not take it easy, because we are different NGOs, different, bureaucracy, different relation mechanism, and partnership is not that easy. So I think, while actually implementing low intensity intervention in US with a partnership with, various organizations, we need to give ample time to understand each other, to understand each other's vested interests, our own criteria, our own interest, and then also our the delivery mechanism, budgeting, and all other aspects need to be understood. Otherwise, we are going to fail. So I think partnership building is a long process, and I would recommend that in our project budget we build enough time, at least 6 months, and the resources to have a joint sessions, to have a site visits to the partners project, and actually speak with the field staff, with the regional staff, with the national staff, and actually have a complete understanding before engaging into a proper partnership agreement. So teaming agreement can be like pre-teaming agreement can happen, and then you understand each other, and then once you are really okay in the real partnership, then only sign the contract. Otherwise, we will actually have a difficult, you know, problem, and we have actually experienced such problems in our global org, and partners were very excited in the beginning, and we thought, oh, it's good, and then actually they dropped out in between. So there are lots of challenges in terms of bureaucracy, in terms of decision making, because we consulted with somebody at a certain level, but the decision makers were at the global level. So these were the challenges that I think we should be very careful while implementing low intensity intervention in US with partnership.
Thank you, Naraj, and thank you, everyone. I can't believe the hour is almost up. I feel like there's so much more that we can discuss. I just wanted to kind of summarize this kind of last portion where in order to truly build that trust and kind of that mutual trust and respect from community members and those that are providing resources, it's that co-development component of the intervention of partnerships, something that we can't rush. And Jonathan, that statement around around AI really perked my ears up, because you're right. There's the thing about kind of these kind of competitor spaces, where that is, as we think about what is the most economical option, as we think about low intensity interventions, how do we position ourselves in terms of building this trust with communities, that this component of a non-AI, kind of digital world, that we can really provide this quality around that mental health support. So thank you, everyone. I just want to share my screen one last time here. And for everyone, thank you. For the audience members, thank you for putting your questions. I'm glad there's a lot of engagement, and we will make note of these questions. I'll share it with the panelists, and I'll send a follow-up email. But just to close out our time today, if we could launch our second poll. This is helpful information for us. Now that you've heard about this conversation around low intensity psychological interventions, you as the audience member, what types of resources would you find helpful? Select all that apply, right? So this helps us to kind of tailor how do we continue the conversation. And as you're completing this poll, I want to share some positive news. So first, the U.S. mental health program here at HealthRight, we have received our first grant funding to implement these interventions among incarcerated populations. Now, this will be a new avenue for HealthRight, but it does still align to our mission of expanding mental health care for vulnerable and underserved populations in the US. And additionally, our next webinar in this series focuses on voices from the community, perspectives on mental health solutions that work. We're featuring a global health advocate and 2 youth advisory board members. More information to come for when that will be scheduled in the coming months. But just to close out, I'd like to thank our panelists for your insightful perspectives. Herman, Matala, Jonathan, Nauraj, thank you. What you've shared today really fuels my passion to innovate mental health here in the US context. And thank you to our attendees. I hope the conversation today has inspired you. I will be sharing the recording, and if you have any questions, please feel free to contact me. But thank you, everyone. Truly, truly appreciate your time today.
Thanks a lot. Thank you.
And if we could stop recording. Okay.